Okay, so we're going to hop into section 5 here. Section 5A, it's chest pain, uncertain etiology, adult and pediatric. If you look over to your left, there is that yellow treatment priorities box that we keep talking about on every protocol. And this one is especially important because it has 2 time constraints that we have to abide by on any chest pain call. I would definitely memorize this if I were you. So the first thing is the 2 and 5 minutes. This means you have to get these 2 things done in the first 5 minutes of patient contact. Number 1 is vital signs. So you have to get your initial set of vital signs. And then number 2 is your ECG rhythm if you're an ALS unit and you have the capabilities to do so. So those 2 things have to be done in the first 5 minutes, vital signs and ECG rhythm. And then below that, you have the 5 and 10 minutes of patient contact. So these 5 things have to be done in the first 10 minutes of patient contact. And number 1 is for adults, if they are less than or above the age of 35, you'll assist them with taking aspirin, and that's going to be 324 to 325 milligrams. You'll see that it says 324/325 in here later on. Each baby aspirin is 81 milligrams, and we're going to give them 4 total of that. So you got your aspirin number 1, number 2 is IV, 3 12 lead, and then 4 if ACS per protocol 5C in an adult, and then 5 is your secondary set of vital signs. So you're going to repeat your vital signs. So in the first 10 minutes, you have essentially 7 things that you need to get done. So just remember your first 5 minutes, vital signs, ECG, and then in your first 10 minutes, aspirin, IV, 12 lead, secondary set of vital signs. So when someone calls 911, what dispatch is going to assist them in is they're going to advise them to avoid any physical exertion or environmental stress. If they have aspirin at home, they'll advise them to go ahead and take 324, 325 milligrams unless it's contraindicated. We'll get into the contraindications of certain medications when we hit the formulary section later on. Probably the most common contraindication for aspirin is going to be an active GI bleed. So if they have an active GI bleed, then they'll go ahead and withhold that. And then if they are previously described for nitroglycerin, they'll advise them to go ahead and take their nitroglycerin dose. So come down a little bit. You got your EMR, EMT. Always start with general supportive care. You'll obtain vital signs and then oxygenation if needed. If you look on this one, it says if it's below 94% at room air. If a patient's oxygen saturation is 94% or greater, we will not administer oxygen. Contrary to further belief, you can over-oxygenate a patient and it can cause harm to them, so we don't want to do that. So if their oxygen saturation is reading at 94% or greater, do not give them oxygen. And then obviously, depending on how low it is, will dictate if we're doing a nasal cannula or non-rebreather. After that, we'll apply the cardiac monitor and then a 12 lead, and then you'll transmit the 12 lead. For adults, if they have not taken aspirin in the last 6 hours of the time of patient contact, then you can administer 324, 325 milligrams of aspirin, which again is 4 baby aspirin, and they'll just chew that up. And that is for adults over the age of 35. And then also with nitroglycerin, if they have nitroglycerin with them for, a previous cardiac condition, chest pain, anything like that, then they can go ahead and take that. The dose is 0.4 milligrams, but you want to make sure you have a blood pressure before you assist them in taking that nitroglycerin, because you're going to tell them to hold off on the nitro if their blood pressure is lower than 100. Reason being, nitroglycerin is a vasodilator, so it can bottom out their blood pressure very, very quickly, especially dependent on what kind of cardiac condition they're experiencing at that time. So less than 100, we're going to withhold nitroglycerin. Scroll down a little bit. We got the intermediate advanced part. They'll establish IV access, and they will treat with fluid. It says 250 milliliter bolus if they have hypotensive symptoms. And obviously right above it, it just says TKO if they're not having hypotensive symptoms. Just be mindful anytime you give fluid. We want to listen to lung sounds, make sure they don't have any fluid on their lung already or present with any signs of pulmonary edema. If they do, then we're going to hold off on those fluids because we don't want to overload them with fluids. If they don't show any signs of that, no signs of pulmonary edema, lung sounds are clear, then we can repeat up to 2 liters as long as we're still treating those hypotensive symptoms. For pediatrics, again, it's the same thing as what we've talked about in the last several videos. 70 plus 2 times the years of age is how you're going to try to figure out that blood pressure to figure out if you're going to treat them for hypotension. And for pediatrics, it's going to be not 250 milliliters, but it's going to be 20 milliliters per kilogram. So another number to keep an eye on. You'll look a little bit further down, you got the paramedic box highlighted in blue. You'll treat any cardiac dysrhythmias, shock by respective protocols. We'll get into that as we get further along in section 5. Analyze the 12 lead, treat per protocol, acute coronary syndrome if indicated, notify receiving hospital immediately if it's a suspected STEMI. We will give nitroglycerin, 0.4 milligrams sublingual, and again, see the contraindications to nitro and erectile dysfunction medications in protocol 5C and 16HH. So we'll hit that a little bit further. Your dysfunctional or dysfunction medications for erectile medicines, that's going to be your Levitra, Viagra, Cialis, and there's our timelines for hours on that we will hit a little bit further into this. If the chest pain is improved with the initial dose of nitroglycerin, then we do not have to administer another nitroglycerin. If the patient's still having chest pain after 3 nitroglycerin administrations and the blood pressure remains over 100, then we can add an additional nitroglycerin per protocol 16HH. Our next course of action would be fentanyl, which is going to be 0.5 micrograms per kilogram, slow IV push, IM, maximum dose of 50. And you can repeat every 10 minutes with the maximum cumulative dose of 1.5 mics per kilogram or 125. So that's important to remember because fentanyl has different maximum cumulative doses for ACS and trauma. So we go with a maximum dose of 50. We can give one more dose of 50, and then we have to cut that in half and give a dose of 25, and then we will finish right there unless you can get permission from OMD after that. If the chest pain is not improved with the initial nitroglycerin, you may treat with opioid option above if indicated. For pediatrics, you have to consult for treatment directives if indicated. So just keep that in mind. Again, I don't know if I mentioned this, so I'll just hit it one more time. Your nitroglycerin is 0.4 milligrams sublingual. You will instruct the patient to lift their tongue. You'll put the nitroglycerin tablet underneath their tongue and it will dissolve. They won't chew on it. You can give that 3 times and their blood pressure has to remain over 100. If their pain still persists, it's not getting any better, then we will go to fentanyl or you can add an additional nitroglycerin. Again, just one more time to hit it, the fentanyl dose, because that seems to confuse some people. For ACS, your maximum dose is going to be 125 micrograms. That's your maximum cumulative dose. You can only give 50 micrograms at a time, but your maximum cumulative dose will be 125. You'll understand why that confuses people once we get into the trauma section, because fentanyl has a different maximum cumulative dose for that. And that's pretty much it. Just treat your patient, not necessarily the monitor. If they're presenting with symptoms and you think something's going on, then make sure you're treating your patient appropriately. Be mindful of the nitroglycerin, especially if they're having an inferior infarct, elevation in your leads of 2, 3, or AVF. My kind of common rule that I think a lot of people would agree with is I don't give nitroglycerin unless I have IV access. Even if your blood pressure is 120, 130, too many times you see someone take nitroglycerin without IV access and then their blood pressure bottoms out and they're not able to get an IV, and then you have a hard time getting their blood pressure back up. So just be mindful of that. Try to get IV access before you give them nitroglycerin, and then don't give them nitroglycerin if their blood pressure is below 100. Any questions on that? Again, feel free to reach out. Pretty self-explanatory stuff. Just remember your treatment priorities, your 2 and 5, 5 and 10, and then your medication dosages.